You're listening to Medscape's In Discussion series on secondary hypertension, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Marwah Abdalla. Dr. Abdalla is a cardiologist, cardiac intensivist, educator, and scientist with expertise in hypertension, sleep, and cardiovascular health. She is the Florence Irving Associate Professor of Medicine at Columbia University Medical Center, where she serves as Director of Education for the Cardiac Intensive Care Unit and co-director of the Columbia Hypertension Center. She served on the writing committee for the 2025 American Heart Association, American College of Cardiology, Multi-Society High Blood Pressure Guideline. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Marwah Abdalla. Welcome to the Medscape In Discussion podcast series on secondary hypertension. Today's episode focuses on hypertension in pregnancy. Hypertensive disorders of pregnancy have important implications for both maternal and fetal health and often require multidisciplinary care. In this episode, we'll discuss hypertension across the continuum of pregnancy from preconception counseling to collaborative care during pregnancy to postpartum management and long-term cardiovascular health. First, let me introduce my guest. Dr. Hoppe is a distinguished maternal fetal medicine specialist at UW Health and professor at the University of Wisconsin School of Medicine and Public Health, with a focus on advancing care and health equity for pregnant persons. Her research has focused specifically on hypertension during pregnancy and postpartum. Dr. Hoppe, welcome to the Medscape In Discussion Secondary Hypertension podcast.
Thank you so much for your welcome, Dr. Abdalla. I'm so excited to be here with you today.
So I'd love to start, and I think it'd be helpful to ground our discussion in the basics. When clinicians hear the phrase hypertension in pregnancy, we know that there are several different conditions that fall under that umbrella. Could you walk us briefly through how hypertension in pregnancy is classified?
Absolutely. So in general, it's just important to recognize that hypertension is classified by some numbers. So in pregnancy, we define hypertension as a systolic blood pressure greater than or equal to 140 and or diastolic blood pressure greater than or equal to 90 millimeters of mercury. We classify this as being measured twice, at least 4 hours apart. And in order to have any hypertension disorder in pregnancy, that's the basics. So the rest of it comes along with how to classify the hypertension. And we have 4 sort of main categories. So we have chronic hypertension, so any type of hypertension before 20 weeks gestation. We have gestational hypertension, which we classify as any hypertension after 20 weeks, but there's no evidence of proteinuria or any other signs of end organ injury. We then get into preeclampsia, which is defined by new onset hypertension after 20 weeks, but now we're starting to see proteinuria or other evidence of organ dysfunction or fetal complications. Lastly, we talk about eclampsia, which is the presence of seizures. So these sort of make up our hypertension disorders of pregnancy. And then we have one other nuanced term called chronic hypertension with superimposed preeclampsia. And so this would include any person who has pre-existing or chronic hypertension, and then they develop preeclampsia features during their pregnancy.
Great. So how common are these different hypertensive disorders? And can you kind of give us a sense of the risks they pose for both mom and baby?
Yeah, so hypertension disorders affect an estimated probably up to 10 to 15% of pregnancies across the United States. And to me, it's important to just say that this makes them among the most common medical complication in pregnancy. Most common types would be gestational or preeclampsia, and then chronic hypertension and eclampsia less so. So some estimates would say the breakdown would look something like gestational hypertension being about 50% of cases, preeclampsia around 30%, and then chronic hypertension about 10 to 15% of those cases, which leaves around 1% or less for eclampsia.
And when you think about particular patient populations, can you sort of walk us through who is at particularly high risk?
Yes. So there's some classic high-risk patients we all worry about. And so those would include patients who have pre-existing chronic hypertension, a prior diagnosis of preeclampsia or other hypertension disorders like we talked about, diabetes, chronic kidney disease, obesity, and other autoimmune disorders like lupus. And then we have other risk categories that include advanced maternal age, so anyone over 35, multifetal gestations. And then we also acknowledge patients with significant social and health inequities, which can affect access to care and other outcomes.
So now that we've sort of gone through the different hypertensive disorders, I'd like to sort of walk through a scenario that clinicians may encounter in practice. And that's, a woman with chronic hypertension comes in for follow up and says, I'm planning to try to get pregnant in the next few months. And for clinicians seeing her in clinic, what would you recommend are the most important things to address even before she becomes pregnant?
Yeah, I think this is so important. So anything folks can do to really optimize their care before pregnancy is important, and we call that preconception counseling. Clinicians should focus on optimizing blood pressure control, reviewing medications that people may use to manage their hypertension and ensure that their pregnancy is safe, as well as assessing for any end organ disease like kidney or cardiac involvement. And then being able to feel comfortable or well versed in talking about the pregnancy risks, baseline labs may be helpful to determine some of that. And then the benefit of starting low dose aspirin when appropriate and pregnant, with the goal of improving their outcomes once pregnant.
I think, most clinicians would start with the medications. Can you walk us through the medication changes that we should consider when a woman with hypertension is planning pregnancy?
So we have some classic pregnancy compatible agents we think about or first line medications, and those commonly include labetalol or extended release nifedipine. There's also methyldopa on the list, but in general, most people practicing these days aren't using methyldopa. So I'd just say our tried and true typically tend to be labetalol or the extended release nifedipine.
And in terms of stopping or transitioning medications before conception.
Clinicians should discontinue any contraindicated medications, which we typically think would be ACE inhibitors. So, for example, enalapril or lisinopril, angiotensin receptor blockers like losartan, and then mineralocorticoid receptor antagonists like spironolactone.
And you mentioned a little bit about, some baseline labs. Are you looking for proteinuria, anything else?
Yeah, so I think of sort of a panel of tests to consider, and some of it really just depends on the patient you're serving. But in general, consideration of an EKG and if there's any abnormalities there, maybe consider a maternal echocardiogram, really to just make sure that the heart is in the best health it can to accommodate pregnancy. And then, especially with people with longstanding chronic disease that may affect their heart and their cardiac function. And then regarding other sort of serum labs, I consider doing a complete metabolic panel, looking most specifically at their kidneys and liver function tests. Again, those are common labs that can be abnormal in preeclampsia, so serving as a baseline. And then urine assessment. So we usually start with spot urine to protein creatinine ratio. And if that is grossly abnormal, considering a 24-hour urine protein to really kind of quantify that. And again, all to look at that baseline proteinuria. Folks who have underlying proteinuria have higher risk of developing complications. And then overall cardiometabolic health. So just really looking into labs or other issues around diabetes, obesity, sleep apnea, because any of those things can drive hypertension. And lastly, rarely I would say if there's any unique or like long-standing severe uncontrolled hypertension, just considering secondary causes of hypertension.
I'd love to transition to think about like home blood pressure monitoring. How do you use it? What are you thinking through, when you're prescribing it for women who are planning pregnancy and who are already hypertensive or already have hypertension?
Thank you for asking about this. So this is really an up and coming hot topic. I think has been used more longstanding in non-pregnant patients, but is important because it provides really a more accurate assessment of baseline blood pressures. And when done, it can really help identify mast or white coat hypertension and also guide medication adjustments before pregnancy. Recognizing and appreciating white coat hypertension, I think, is undervalued, but prevents overtreatment based on misleading office readings and allows clinicians to really better tailor therapy and assess true risk. This is really underappreciated and really not particularly known about in pregnancy, but a lot of my patients come and they're like, I have white coat. And then the problems come later when they're having hypertension and we just call it preeclampsia. So I think really the guidelines from AHA, and there's one nice paper that talk about assessing for white coat before 20 weeks of the pregnancy, and home blood pressure monitoring exactly can help with that. So I think bringing more awareness to this is important.
Yeah, that's really helpful. And I think a practical issue that comes up is actually making sure The basics are covered that patients are using a properly fitted cuff and a device that's actually validated for use in pregnancy. I'm always surprised that people don't know that not all devices are because accuracy can vary quite a bit between monitors. And I've found resources like validatebp.org helpful when checking whether a device has been validated.
And that list keeps growing. So I think I always put that in my patient follow-up notes. And every time I talk to somebody, I'm like, I make sure, please, that you are recommending a device from there. And then
Yeah.
also trying to avoid wrist cuffs too.
Yes, absolutely. Absolutely. So, sort of staying with this preconception scenario, some woman may be pursuing IVF or other fertility treatments. So, does that change her risk of hypertensive complications during pregnancy? And should clinicians approach blood pressure management differently in these situations?
I think that's a great question. So I think the general answer is yes. So patients conceiving with IVF or other fertility treatments in general have higher risks of hypertension disorders, but it's likely related to factors underlying their infertility causes or perhaps advanced maternal age, maybe higher rates of multifetal gestation or other reasons that may make it difficult for them to become pregnant. So I would say blood pressure management, however, kind of the principles remain the same. We should be attentive to their baseline risk assessment, have early monitoring and kind of prevention strategies. However, uniquely for folks with IVF, I think it's really just important that optimal blood pressure control is obtained with pregnancy safe medications before undergoing IVF. I think people put a lot of resources and efforts in getting pregnant. And then, for example, to find out my pregnancy outcome might not go so well because my blood pressure is not controlled. Or, for example, I'm on 3 blood pressure medications and it would be very hard to carry that pregnancy. So I think there's some unique nuances to this. And I think the end recommendation is just really making sure their baseline risk is known and that any efforts to make full blood pressure control and management adequate would be a really great step in the right direction.
Yeah. So let's say she becomes pregnant, and often we have to think about multidisciplinary collaboration. And would love to get your sense of what an ideal collaboration should look like when managing a woman with hypertension during pregnancy.
Ideal collaboration really involves clear communication and really a shared responsibility. And so I think one troubling issue is that a lot of this care lives with primary care. And young folks don't always engage with a primary care provider. And so I think really helping people find a primary care provider to, achieve adequate health before pregnancy is key. And then a way to even encourage referrals for preconception counseling to an OB or high risk provider, because then I think that handoff is just much easier. And then, from one appointment to pregnancy, then they have a plan. And then also that primary care physician knows what the plan is from the obstetrician too, of, what the expectations would be in that first 8 to 12 weeks before their prenatal care really starts. So I think that's really important. I think regular information sharing, aligned blood pressure goals are really important. And then the message of don't stop your medications, right? So if you're controlled on your medications, you're on a safe pregnancy medication, people can feel comfortable then walking into their pregnancy and maintaining all of that and know that it's safe and healthy for their pregnancy.
I'd love to pick your brain a little bit at how clinicians should be thinking about ongoing blood pressure management. You hinted about it, but in terms of who's adjusting the medications, when she's pregnant, does it matter by the hypertensive disorder in terms of what you're targeting to?
Yeah, so this is a great question. So now that this person's pregnant and in the OB's office, typically the primary is no longer involved, I would say, in most practices. So, really important for that OB to feel comfortable. And a lot of OBs may feel comfortable managing, for example, chronic hypertension. Some may not. So, some may end up in a high risk OB clinic. And I think geographically that may vary depending on where people practice and practice patterns. But the goals for management are different based on the type of hypertension. So if you have chronic hypertension, the focus is maintaining that blood pressure control consistently less than 140 over 90. Again, using pregnancy safe medications with regular monitoring throughout the pregnancy. And I spend a lot of time drawing pictures and diagrams for my patients because naturally the blood pressure will drop a little bit in the first trimester and then probably it's back to its baseline around 18 to 20 weeks and then gradually increase. And I typically see the highest, the day of delivery. I tell my patients it's normal your blood pressures are going to go up. It's pretty expected. You'll need to add medications or titrate medications. So then they know that when that happens, they're not scared or that there's a problem. And that looks really different for somebody who does not have hypertension or chronic pre-existing hypertension, but new onset like gestational preeclampsia, as we talked about before. The typical recommendation and guidelines are that we don't treat gestational hypertension or preeclampsia until their blood pressures become severe. So the blood pressure criteria we use for that is greater than or equal to 160 over 110. So I think that's just a really distinct difference. There are some trials going on and really looking to see could there be benefit of treating those, to a lower threshold and maybe pregnancies would last longer, but that's just not our current practice and the evidence doesn't support that at this time. So the focus for people then, with new onset hypertension is really following their labs, making sure the mom and the baby are healthy. And sometimes that actually requires inpatient stays to maintain safety. And then we treat at that threshold. And sometimes people can stay pregnant longer, but usually that's done on the inpatient side of things.
Right. And for someone who's not in the severe range, and you're managing their hypertension while pregnant, how frequently are you telling them their blood pressure should be monitored using home blood pressure monitoring, for example?
So that's a great question. We also don't have guidelines or recommendations for people with non-severe gestationally related hypertension on home blood pressure monitoring. So I think the ideal would be that people would have a device, they would be able to check daily at home. And if those numbers are increasing, they should seek care. However, the reality of it more is that we see them in the clinic twice a week and they do blood pressure checks and fetal monitoring, which is something called non-stress test, where we're checking on the baby's well-being. And so I'd say at a minimum, they come in for 2-week in-person checks, and that's sort of the gold standard. And then anything above that is extra, but
Hmm.
I also think really important. So I hope that answers your question.
Yeah. You talked a lot about how blood pressure changes. So when you're thinking about this, are there particular points where hypertensive complications are more likely and you're more worried about mom and baby during these particular points?
Yeah, I would say in general, unless somebody has chronic or pre-existing disease, we don't really worry about people until after 20 weeks of the pregnancy and probably more specifically 24 to 28 weeks. So a lot of the blood pressures, that are going to be new onset or manifest are really going to come at the end of the second, early third trimester. And interestingly, prenatal care becomes more frequent at that point. So we see patients every 2 weeks, starting at 32 weeks, and then every week starting at 36 weeks. And I think naturally, again, thinking about when hypertension becomes more of an issue, we're seeing patients more frequently. And then a lot of our high risk patients, we'll see them twice weekly actually for all that testing I talked about. So, for example, like pre-existing diabetes or a lot of the high risk patients I reflected on before will be coming in twice a week starting at 32 weeks.
And what about aspirin prophylaxis? I think that's an underappreciated concept for most people.
Yeah, interestingly, that is definitely underutilized as I understand across the US. And so aspirin is really the only preventative strategy we have to try to lower the risk of preeclampsia. And without sort of rattling off the long list, a couple go-to places would be looking at the ACOG or USPSTF recommendations. And so they recommend anyone with high risk factors or conditions start aspirin, low dose, 81 milligrams, around 12 to 14 weeks of the pregnancy or by 16 weeks. And then anybody who has two or more moderate risk factors would also be someone to consider recommending aspirin. And even though these recommendations have been out for quite a while, the uptake of it is lagging.
Yeah. I mean, I know in the 2025 ACC/AHA guidelines that was definitely, added in there to heighten people's awareness that aspirin prophylaxis is recommended. So I'm hoping that as more people understand this, that it becomes a little bit more implemented. So let's fast forward 9 months later. Hopefully, she's delivered a healthy baby. She's beginning to transition back to her primary care clinician. What's the typical blood pressure trajectory now look like in the postpartum period?
Well, this is just an exciting period for me. So, this is where I spent a lot of my academic career and research trying to improve. And so, blood pressure typically improves right after delivery, which a lot of people think, I'll just say in parentheses, are cured or, nothing's going to happen because they've delivered, the placenta's out, and their blood pressures are going to be fine. But the reality is, we're learning that the blood pressure often is peaking or spiking about 3 to 6 days postpartum. And why exactly could be due to fluid shifting or other kind of hemodynamic and physiologic changes. But then the blood pressure will gradually decline and often pretty much recover by 2 weeks in over half the patients. But there's also about 30% of people in my practice, I would say, that still have hypertension at that 6-week endpoint. So there's a lot of dynamic changes happening. And I think the takeaway is that people need to be followed really closely through those 6 weeks because truly blood pressures do misbehave after they leave the hospital.
Yeah, I find that there's so much variability when I see patients postpartum accepting them back. So I know for myself, I've always questioned like, what should be the blood pressure goals and medication titration strategy in the early postpartum period. And obviously, from my perspective, when should I transition back to standard long-term ACC/AHA aligned targets such as 130/80 for a woman who's postpartum?
Unfortunately, we don't have robust evidence to define that ideal blood pressure target in the early postpartum period. So early on, I think more of the focus is on safety and avoiding severe hypertension, which include other key outcomes like preventing readmission, stroke, heart failure, rather than really following a strict long term treatment goal for preventing long term cardiovascular disease or poor outcomes. As a medical provider, I would say that we're often accepting of blood pressures way above 130/80, and that some of our old guidelines even used to say just keep the blood pressures less than 150 over 100. As I have thought about this, it's like, why would we consider that? And I think some people are worried about people dropping too low, for example, on medications, especially if they don't have chronic hypertension and knowing that this period is really dynamic. And we'll get into this in a little bit, but I follow and treat a lot of people with postpartum hypertension. And we tried following those guidelines. And so about 60% of people were having some sort of spike after they left the hospital that required medication initiation or titration. So, and I would also echo most of the experts in this space across the country agree that we should really try to be optimizing people's blood pressure less than 140/90 before they leave the hospital and then through those 6 weeks postpartum. And then probably more at that 6 to 12 weeks, kind of really look at transitioning towards those ACC/AJ targets like 130/80.
So during this period, she's coming in maybe to primary care, she's still following up with you guys. Who typically should take the lead in adjusting blood pressure medications postpartum?
Another excellent question. So, in most provider practice groups, it's usually a shared responsibility. The obstetric team often leads blood pressure medication adjustments in the immediate postpartum team when that risk is the highest and patients are really closely followed. But as things stabilize, I think care should really intentionally be transitioned back to a PCP and maybe in some places cardiology for longer term blood pressure management. Uniquely, there are a lot of places, primarily academic centers, but even more centers I'm hearing very frequently are implementing remote monitoring programs. Ours is called Staying Healthy After Childbirth, and we provide daily monitoring and surveillance really for postpartum patients. And
Hmm.
in this unique environment, we have a specialized nurse team that really takes care of all the patients and supports, any blood pressure changes, med adjustments, et cetera, needed. So I think this is kind of a growing area and, depending on the facility and resources that you may have, this works really well. And allowing nurses to use, delegation protocols to escalate care can be really quite effective. Really different than like the traditional care model where a provider is responsible for all the patient blood pressure management.
I mean, I think it's a fantastic program, incorporating remote monitoring. I'd love to hear just a little bit more and what lessons you think clinicians who may want to do this, in other centers might be able to apply in their own practices to improve postpartum care.
Our research in this space and care model really started in 2016, and we demonstrated early evidence that this care model can reduce postpartum readmission. This was a kind of a fancy outcome that really allowed us to go to our hospital administration and start a standard of care program, which kicked off in 2019. We've now served over 10,000 patients. We iteratively review our care model, patient outcomes, mostly our readmission rates, and really are proud to say that our readmission rate in 2025 was 1%, which is
Wow.
outstanding. And I think the root of this is just consistent care with one team. That's really quite successful. So given the limited time today, I think really a full scale remote monitoring program, may not be an option for some practices, but learning how to teach patients really the basics of self-measured blood pressures, providing educational instruction sheets on how to do that at home because it's hard to remember what you were taught perhaps.
Hmm.
It's important to have good technique for adequate results and reliable results. So then where to assist your patients in getting a device. We talked about the validated blood pressure device lists and making sure people are getting devices that are appropriate for them. And then a plan that works for your practice to review results with your patients in a timely fashion. So I think talking about full scale remote monitoring is really complicated and could be a whole nother discussion. But I
Yeah,
think
for
those
sure.
takeaway points I think can be really implemented in anyone's practice.
So medications, especially in breastfeeding women that you may see, is always a hot topic. Which antihypertensive medications are generally considered safe, and what are the resources you recommend to clinicians when evaluating medication safety during lactation?
I think one of the most common reasons people worry about taking antihypertensives really are because they don't want to hurt their baby and they want to breastfeed. So, common choices, first line agents would be labetalol, nifedipine, amlodipine, or enalapril. And these are all generally considered safe and commonly used postpartum. Methyl-dopa still remains on a lot of lists, could be safe, but usually are often avoided because of mental health side effects with methyl-dopa. So I hesitated to bring that one up at all, but it is listed there. So my favorite tool at this point is the American College of Cardiology or ACC Postpartum Hypertension Clinic Development Toolkit. Within there, there's a list of safe postpartum medications as well as safety profiles for lactation. So I highly recommend that list for a resource.
So before we wrap up, I'd like to zoom out for a moment and think about what happens after the immediate postpartum period. Obviously, we talked a little bit about gestational hypertension and preeclampsia, but some of these patients may feel well after delivery and may not reconnect with medical care for several years. And I think you mentioned that before. Where do you see the biggest gaps in follow up care for women who develop hypertension during pregnancy and who may no longer be engaged with the healthcare system?
Yeah, I think this is so important and really a huge initiative moving forward, kind of in our practice. I think a lot of it stems with insufficient patient education prior to delivery, where people have the ability to kind of really think about things. And then postpartum, it's a huge missed opportunity to share long term risk of cardiovascular disorders after having a hypertension disorder of pregnancy. I think also when people feel well, there's not a problem, right? So the most common symptom I often tell people with high blood pressure is nothing, right? You feel well. And so you don't really feel like you need to engage with care. So I think leaving people with proper education and knowledge, which can empower them to really be an advocate for their health, is important.
On the other end, clinicians seeing a patient maybe several years later, patient with a history of gestational hypertension or preeclampsia, what should be different about how they approach her long-term cardiovascular care?
Absolutely. I think we're starting to recognize hypertension disorders as a modifier to cardiovascular risk. So that's great. Patients with a history really should have earlier, more frequent blood pressure checks, routine screening for lipids and diabetes, as well as lower thresholds for prevention. Again, hypertension in pregnancies are early warning sign, and we should treat it like a lifelong cardiovascular risk factor. So we should stop thinking of it as a result of pregnancy complication.
Yeah. So we started this with a woman who comes in wanting to be pregnant. She's delivered a healthy baby. Now she's going to come back and say, what about future pregnancies? How should clinicians counsel patients who previously had, hypertensive disorder pregnancy about their risk for future pregnancies? And are there steps, we can take before early in pregnancy to help reduce those risks?
So I think letting people know that having had a prior hypertension disorder does increase their risk of recurrence. It's probably estimated to be around 20%. And I always tell folks likely higher in those who had early onset disease or severe hypertension disorders. But before your next pregnancy, I would always tell a patient that clinicians, we can help optimize their blood pressure, make sure they're on safe medications, optimize weight, which can be a really hard conversation to have with people, and any other comorbidities, like, for example, untreated sleep apnea. I think all of those provide a huge opportunity to improve health going into a next pregnancy. And as we optimize health outside of pregnancy, we can really hopefully have a more successful next pregnancy. And then I always close with saying, you're more likely to have a successful, uneventful pregnancy than another hypertensive pregnancy. So I think I always try to provide a little hope there. And then also putting a plug in for people to maybe purchase their aspirin and make sure that they started at 12 to 14 weeks, as well as, how can they monitor their blood pressures, be an advocate for their own health, and then hopefully have a successful outcome.
So, these are difficult conversations, especially for women who may have experienced complications related to hypertension during pregnancy or the postpartum period. It can feel particularly vulnerable. How do you talk with patients about their future cardiovascular risk in a way that's informative and empowering without creating unnecessary anxiety.
Yeah, I think this is really important and something that probably us obstetricians maybe don't do the best at, but I think one life at a time, it all matters. So my typical approach is framing counseling around future cardiovascular risk as information, but not a diagnosis. I often state that education can often help empower people to take control of their health. And I teach strategies on how to do that so people can feel more empowered. I acknowledge their experience. I ask them to share their story. I want them to call it out so they feel heard. A lot of people have trauma that they haven't dealt with. And so I think that's important to find resources for that if needed to process that. And then I explained that hypertensive pregnancy is an early warning sign. It's not a guarantee and that they're going to end up having a cardiovascular problem down the road. I use motivational interviewing to explore what matters to them. So I think I emphasize small, achievable steps in shared decision making. So patients really feel informed, supported, and empowered rather than alarmed. I share resources for different lifestyle behavior changes that can improve their cardiovascular health. And then I always let them know I'm a resource. They can contact me. And I also share like Life's Essential 8 and other websites and resources that they can look at. And then I know this might be out there and not applicable to everyone, but in my group, we have been studying and trialing health coaching, which we've demonstrated to be really effective in kind of keeping people engaged through that first year postpartum. And so I'd love to see more of that down the road to support people well beyond those first 6 weeks postpartum.
Yeah, it's a very comprehensive approach, and I think lots of lessons to be learned, and I think important conversations to have because I could tell you as a cardiologist, seeing the outcomes much later, always wanting to say, "Oh, could we go back in time and have what you basically just outlined as a conversation so that they understand what it may look like later on." Before we close, I just want to ask you briefly 3 key things, you think every clinician caring for women with hypertensive disorders of pregnancy should remember.
So this is super hard. And I think I had a list of 10 or more, but we've covered so much today. So, first, postpartum hypertension is common, it's dangerous, and don't underestimate it. I often share with patients one of the most common symptoms of high blood pressure really is no symptom at all. So, relying on how you feel is not sufficient. And because severe complications can develop before anyone realizes a problem, this is a really important take home message. I think that's also why measuring your blood pressure rather than trusting symptoms is what can protect outcomes and help people be safe. Second, blood pressure peaks after discharge, so after people have their baby. So being proactive with follow-up really matters and engaging with follow-up really matters. So this is one huge reason that I'm a big advocate for self-measured or home blood pressure monitoring or finding solutions for remote monitoring in your healthcare system or even low-tech strategies to allow this to be possible. And then third, hypertensive disorders of pregnancy are a cardiovascular risk marker. So what happens in pregnancy should really inform care long after delivery.
Wow. Thank you so much, Dr. Hoppe. It's been a fantastic conversation. I've learned so much. I really appreciate you taking the time and sharing your expertise. It's such an important topic. And I know I will be learning much more through the resources that you also mentioned. So thank you again.
Thank you so much for having me today. I truly believe that, any little thing that we can change or learn or do really will save lives. So it's really a pleasure to be here, and I'm always happy to be a resource.
Thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on secondary hypertension. This is Dr. Marwah Abdalla for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Secondary Hypertension podcast series with our host, Dr. Marwah Abdalla. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on secondary hypertension.